Bismillahirrahmanirrahim. Assalamu alaikum, everyone. Welcome to the MDI Health Hour. I'm Dr. Amir Daud. I'm a community pediatrician working in Calgary. I will be your moderator today. MDI is arranging weekly webinars on a number of topics. We have had few webinars on different aspects of COVID-19 for general public and health professionals in the last month. Now we have been hearing a lot about people being tested positive and then tested positive and then they improve and then they tested positive again after being negative, and there have been confusion. And now another thing is that the province has been reopening the markets and everything. So economy is opening. So public health perspective is coming in. So the topic of today's webinar is COVID-19 testing and public health perspective. Today we have two very respectable, renowned, and highly qualified panelists who are experts in their respective fields. And just to tell you one thing, we will be taking your questions, and we have a question answer sessions, and you will have to post your questions on your screen on the right side. There is a Q&A call tag. You can just open it and write the questions. And all the questions that are written, that they will be answered on first come first basis. So I was asked to give a brief introduction about these panelists, which is not an easy task, considering their list of impressive qualifications and achievements, but I will try my best. So first I'll talk about Dr. Mohammed Imran. Dr. Imran is a public health specialist. He did his MBBS from Pakistan, and then he did his master's in public health and a master's in population and international health from Harvard University. He is a presidential gold medalist and a Fulbright scholar. Dr. Imran is currently based in Calgary and works as a senior HIV and TB technical advisor at Save the Children US. He's also the technical lead for several HIV, TB, malaria, and other public health projects in Nepal, Myanmar, Philippines, Bangladesh, Papua New Guinea, and Bhutan. In the past, he has worked as monitoring and evaluation advisor with Government of Pakistan, DFID, UNICEF, UNAIDS, and has been the principal author of various articles and publications. Welcome, Dr. Imran.
Thank you very much. Thanks, Dr. Ahmed.
So my other distinguished panelist is Dr. Imran Mirza. Dr. Imran Mirza is the provincial medical lead in molecular pathology, Alberta Precision Labs, previously the Calgary Lab Services. He's working to transform the molecular pathology labs in Alberta into a cohesive provincial program. He's also a clinical professor in the Faculty of Cummings School of Medicine, University of Calgary. He's an internationally recognized expert in laboratory hematology and molecular pathology, with medical training in Pakistan and USA and medical leadership experiences in Canada and UAE. He holds fellowships from Royal College of Physicians and Surgeons of Canada, College of American Pathologists, American Society of Clinical Pathology. He is a diplomate of American Board of Pathology in 4 specialties: anatomic pathology, clinical pathology, hematology, and molecular genetic pathology. And then I would like to just mention that the panelists have declared no relevant financial relationships within the past 12 months with commercial interests that provide products or services related to the content of the educational activity. So welcome, Dr. Imran Mirza and Dr. Mohammed Imran.
Thank you very much, Dr. Ahmed.
Thank you, Dr. Ahmed.
I will start today's discussion by my first question with Dr. Imran Mirza. So what do we know about COVID-19 virus and how that knowledge has allowed us to test for infection with this pathogen and with this new confusions in people arising about testing negative and positive again?
Sure. So, Bismillah ar-Rahman ar-Rahim. I would like to start with first thanking MDI's leadership and the organizers for this opportunity. I would also like to state first that any views that I express are my own and do not represent Alberta Precision Laboratories, Alberta Health Services, or University of Calgary. The question that is asked that you asked is fundamental, and I would like to take the opportunity to share some images to highlight what I have to share with the audience. Going here. What we know about this virus is that it belongs to a family of viruses called Coronaviridae. We know about 4 viruses which are common respiratory pathogens and have long been in circulation in humans. And they are listed on the right, on the left side of your screen. Those include 229E, HL63, OC43, and HKU1. Most of these viruses have their origins in mammalian hosts. The lethal coronaviruses that we have recently encountered starting in 2002 with SARS jumped from bats to humans through an intermediate host known as civets. While I was in the Middle East in the past decade, there was emergence of Middle Eastern Respiratory Syndrome virus, or MERS-CoV, in 2012. And that has jumped from the bats to humans using an intermediate host of camel. Now, this particular virus, we don't know the intermediate host, but it has its origin in the bats, and it is now spreading in human society. This virus is an RNA virus with a single positive strand, and that strand is encapsulated with nucleocapsid proteins, which are then covered by a lipid bilayer membrane derived from the host cell. This membrane has envelope proteins and other membrane proteins, as well as a spike protein. And it is through spike protein that the virus binds to human cells, specifically through the angiotensin converting enzyme 2 receptor. So the life cycle of the virus is that it attaches to the ACE2 receptor on the host cell, and a serine protease called TMPRSS2 cleaves the spike protein, which allows the virus to be engulfed in a vesicle into the cell. The membrane of the virus later fuses with the membrane of the vesicle and releases the RNA, which the RNA-dependent RNA polymerase of the virus creates multiple copies of. It uses host translational machinery to create proteins, and those viral proteins allow for replication and assembly of the virus particles in the Golgi apparatus, which are then released. So as a cell creates more of these virions, it's sort of the viral process takes over, and the cell also attracts immune response and it dies. So the viral genome is the one which is used to develop all the nucleic acid tests that are currently in use. And it is a very large genome. It's about 30 kilobases, or 30,000 base pairs long. It's one of the largest viruses that we know of. It is about twice the size of influenza virus and about 3 times the size of HIV virus. About 2/3 of the viral RNA is used to encode for the proteins that are part of its replication cycle, or the replicase system. And on the right side, about a third of the viral genome, as you can see, encodes for other structural proteins such as spike protein, envelope protein, and others that you can see. So the tests that we are using in the laboratory use the S protein, envelope protein, M protein, and the RNA-dependent RNA polymerase to amplify and ascertain the presence of the virus.
Okay. Thank you, Dr. Imran Mirza. My question with Dr. Mohammed Imran is, so what is a pandemic? And how you differentiate between an epidemic and a pandemic? Because since this COVID-19 started a few months back, there have been a lot of talks about comparison with flu vaccine, and we know which is present all over the world and which affects every autumn and fall and winters in countries. So can you explain? This is a basic question, but it creates a lot of questions, questions about this thing. Thank you,
Yeah.
Dr. Mohammed Imran, please.
Thank you, Dr. Amir. And first of all, I would just like to thank the MDI for giving us, this opportunity. I think, public health is something which is always, very important. But with this coronavirus, it has literally brought, I would say, a lot of, interest into the public health. So in order to just, answer your question, I would just like to share my screen. So can you see my screen?
Yes, please. Yes.
So Dr. Amir, I think the issue is whenever, we see outbreaks happening in the world, we see that these terms like epidemic, pandemic, endemic, people start using these terms. And what we have seen is that in most of the cases, these terms are used inaccurately or interchangeably. So it's very important that, we have a clear-cut understanding of what does it mean when we say it's an epidemic or it's a pandemic. So in this slide, I've just tried to define what I would say the most common way is to define these terms. So when we talk about the epidemic, so it is a disease when it affects many people at same time, and it spreads from person to person in one locality. And in that locality, if the disease is not permanently prevalent, then it's said to be an epidemic. And we have many examples of the epidemic. And usually when, WHO uses the word epidemic, they mean to say that, there is a disease which is more common in one region or in one community. But when we talk about the pandemic, so at that time, we more talk about the worldwide, spread. And in the context of the COVID, this word of pandemic is very relevant because this is a disease which has really crossed all the continents. And right now, the data shows us that there are more than 220 countries in the world where we have COVID-19. So this is a classical example where we see a disease which has crossed the country's borders, which has crossed the continents, and we are seeing that at the global level. So that is a true kind of a pandemic. And sometimes, I would also like to highlight another term which we very commonly use in epidemiology, and that is endemic, which is used when we talk about the basal level, of a disease in a community. And I think very commonly, we use this word endemic of malaria, you might have heard when we talk about various African countries, we say malaria is endemic, it's something which is common, at a basal level. And then I think it's also important to have some clarity on the word, outbreak as well. And we have heard, this word very commonly in the past, especially I would say in the context of Canada and Alberta as well, where there has been several outbreaks. So outbreak is just a sudden eruption of cases in a locality or in a particular kind of an environment. So that's how I think these terms are differentiated. And when we talk about these terms, they need to be differentiated accordingly. Coming, Dr. Ahmed, to the second point of your question, when we talk about the flu and COVID-19, I think one thing we need to understand right from the beginning, and that is when we talk about the normal seasonal flu, it's not we are talking about the pandemic. So literally when we talk about the pandemic flu, then there are two obviously scenarios that the world has seen in terms of the flu. So one of them was the swine flu, which happened in 2009. And we know it infected around 1.4 billion people and killed 151 to 575 people, as per the CDC data. And then about 100 years ago, there was a Spanish flu, which affected 1/3 of the planet's population, and so many people were killed as well. But like, in the common kind of like, people, common man's like, understanding, when we talk about the flu, and then, we try to differentiate it from the COVID-19. If you see from this, like, table, I've just tried to like, give some, I would say, the important areas which, kind of like, highlight that how these two are different. So obviously one is the etiology. The virus for the flu is different compared to the COVID-19. And I think, as my friend Dr. Imran Mirza has already alluded, like, there are 7 viruses in the coronavirus family which can infect people. And among them, 3 are the most important, like MERS, SARS, and now we are talking about the COVID-19. The second thing is, I think, the signs and symptoms, which is like, also very important. And we have seen, like, as far as the signs and symptoms of these two diseases are concerned, they are very similar, and it's very difficult to kind of like, differentiate. But still, I think on the COVID-19, we are learning more and more, and some of the recent, like, inclusion in terms of the signs and symptoms, like the loss of taste or smell, is something which is more specific to COVID-19 compared to flu. And then we have also seen clinically that, flu mostly affects the children, while the COVID-19, like, it mostly affects the old people, and old people are like, they're more kind of like, susceptible. Then I think another important point, specifically, I would say from the public health point of view, is the hospitalization rate. I've just given over here some US data, but like, we know that as far as the hospitalization rate is concerned, it's like, relatively low, like, in flu compared to the COVID-19. And also in COVID-19, like, when we talk about the specific age categories, with the increasing age, the hospitalization rate is more. And same is the case with the mortality, which is like, high in COVID-19 in certain age groups compared to flu. And then we all know, like, as far as the preventive aspects are concerned, for flu, we have vaccines available, we have some treatments available as well. But for the COVID-19, we are yet to like, find a vaccine or even a treatment, even though there are more than like, 80 trials which are going on across the globe. But then this last point, I would just like to, I think, emphasize, because from the public health point of view, this is the most important point. And this is basically, a term which we use very commonly in the public health, and it's known as the R naught, or the reproduction number. So it means that how quickly this epidemic or this disease basically spreads from one individual to another individual. So the value of this R naught for flu, like, what we have seen from most of like, our experience and studies, is around 1.3. While this value is way high in case of COVID-19, and the latest kind of like, literature tells us that it's usually in between 2 and 3. So that means that this is an infection, which spreads very kind of like, rapidly. So I think these are some of the important differences from the public health point of view between flu and COVID.
Okay, thank you, Dr. Imran. From what you said, that it is clear that flu is an epidemic. It occurs seasonally, and it has a lesser mortality rate, and R naught value is not as bad as for the COVID, where COVID is spreading at the same time all over the world. And that makes it an pandemic. And your presentation will make it clear for a lot of people. You have made it very easy to understand everything. And before coming back to Dr. Imran Mirza, so you gave us a very brief and excellent description of how the virus originated and how it spreads, how the intermediate host is responsible or is important in that. And at this time, we don't know what is the intermediate host in COVID-19. Now, I would like what you have told us. My question is that we know that whenever we get viral infections or even bacterial infections, we develop an immune response. And this is the basis of a lot of vaccinations, that when we develop an immune response, that once you get measles, for example, you will develop immunity, and you are less likely or not likely to develop measles again, or like a polio. If you get polio, you are infected by polio, you develop an immunity, and you are not likely to develop the immunity again. My question is, what kind of an immune response does this virus generate? And how much protection, how much protection it provides for reinfections? There have been concerns given as some patients have tested positive for the virus, and when the symptoms improve, virus was negative, and then the virus again became positive after a few weeks. So before letting the mic to Dr. Imran Mirza, I will let, because of the new participants have joined, if they have any questions, they can click on the Q&A tab on the bottom of the screen, and then they can write the question, and we can answer the questions one by one after the initial discussion. So Dr. Imran Mirza, this is over to you, please. Thank you.
So thank you for the question. And I'll be happy to share with you the immune response that the host generates to coronavirus. This is a graphic from a recent paper from JAMA that's published online, which I think illustrates beautifully in terms of what happens, both in terms of the level of viremia that is detectable by nucleic acid testing using RT-PCR, and also the immune response, and mostly the serological response that is generated in the host. So as you can see here, the PCR nasopharyngeal swab that is used for PCR testing is the way to diagnose this condition in an acute state. And virus can be isolated from respiratory tract of these patients for a week to 9 days. But then the host immune response, mostly the B cells, start producing antibodies, which are IgG and IgM antibodies, that are detectable in the second week after the onset of symptoms. And these antibodies now are being used for the detection of people who have been either had asymptomatic infection or have recovered from infection. What we know about this antibody response is that in patients who have a brisk antibody response, have high titers of these antibodies based on ELISA tests that are available in the market, that these antibodies do offer protection from reinfection. So one can say that a high titer of antibody is assumed to have neutralizing antibodies against the virus without testing for neutralization using complex assays in the lab. So the IgG and IgM responses are, as you can see, the purple and the green broken lines on the illustration. And then the IgG response sustains, but the IgM response sort of tapers off by week 6. So if you look at the type of tests that are available to detect SARS-CoV-2 or COVID-19, the nucleic acid test is currently the test that is used for the diagnosis of acute infection. And this is based on the nasopharyngeal swab, but we have used other specimens in the laboratory as well, such as the oropharyngeal swab, sputum, bronchoalveolar lavage, and other fluids, including urine and stool. The value of this test is that it informs for the individual that they have an infection, and informs patient management and actions needed to prevent transmissions, such as quarantining and asking people to stay at home. And it also informs actions needed to prevent transmission from public health perspective. The immune response is used, and as it is there, for us to use those antibodies to detect susceptible individuals who are antibody negative and those that are previously infected, so as to separate them. It identify individuals with neutralizing antibodies, and that has implications for experimental therapies such as the convalescent plasma that is being given from patients who have a brisk antibody response, and it is kind of a passive transfer of immunity from them to those who are seriously ill. And it also facilitates contact tracing and surveillance. And it is, I think, here that the public health teams are really excited to have these tests. So what we know about the breadth and the depth and the effectiveness of the immune response is unclear at present. The examples you gave, Dr. Amir, for example, measles, immunity against measles is lifelong. But influenza, it just tapers off in 6 months. So that's another story. What we know from the related coronaviruses is that the SARS immunity to SARS has been detected for up to 2 years, and for MERS-CoV up to 3 years in patients who have recovered. So so if we extrapolate that, we believe that the immune response that is generated and the immune memory in these patients is going to be protective, at least for some time. But it needs to be tested, and we can't say for sure whether the immunity that these people have developed is protective in the long run.
Mhm.
Okay, thank you, Dr. Mirza. So I think so at this point, we are uncertain about the long-term immunity and what it entails for protection after infection.
That's correct.
Yep.
Yes. So because I think it is such a rapidly developing field, every day we are getting new research and new thing, and we'll be hearing a lot about this in the next few weeks to months. And hopefully we have some good news about this.
And if I may add that, a lot of discussion has been on the B cell or antibody response, but T cells are also important. And there was a study published from China that looked at 175 patients who had recovered. Out of those, 10 had no undetectable antibodies. So the assumption is that they probably had a T cell response to the virus that allowed them to recover from the infection. But that, again, needs to be looked into.
So cell-mediated immunity may also come into play.
Yeah.
Okay, so I will come back to Dr. Mohammad Imran. So we have heard a lot about herd immunity.
Yeah.
So this is a term that has been, there has been a political discussion about this. The New Zealand Prime Minister mentioned that I did not allow anybody to go into the place so that they do not expose anybody. In the US and in some countries, there were discussions that and there have been a lot of videos circulating. If we allow people to distance themselves and continue social distancing, that would not allow the herd immunity to develop. So there has been, and because as you know, the polio is one disease that its control dependent a lot upon herd immunity. And so my question with Dr. Mohammad Imran is, can you explain what is herd immunity and how does this play a role when it comes to COVID-19?
Yeah, thank you, Dr. Amir. I think your question, gels into, very well what Dr. Imran Mirza was already kind of alluding. So I'll just try to explain, what herd immunity is. And, you're absolutely right. There has been a lot of, discussion around the herd immunity. So actually, when we talk about the herd immunity, people have a variety of meanings of this word of herd immunity. So it can be proportion immune among individuals in a population, or it can be a particular threshold of population of immune, individuals that should lead to decline in the incidence of a new infection, or it can be a pattern of immunity that should protect a population from invasion of a new infection. So by these terms, what I mean to say is that when we talk about the herd immunity, we are actually trying to say that how many people in a community, they are already kind of immune to the disease. And this immunity can come two ways. One is obviously if there is a vaccine, and when the people are vaccinated, they become immune. And then the second thing is when the people, they get infected. So when more and more people get infected, then as Dr. Imran Mirza was already explaining, that there can be a T cell mediated or B cell mediated or antibody mediated response, and that ultimately gives the people immunity. And from there, actually, this whole concept of the herd immunity comes in, and we say that a common implication, the risk of infection among the individuals is reduced when they come in contact with an individual which is already immune. And that is from where we are deriving this word of the herd immunity. So in my slide on the right side, again, I think you would see that word coming in, which we call as the reproductive number, or R naught. So if you say on the A, diagram, you would see in an infection which has an R naught of 4, one individual which is infected can infect 4 individuals. And then each of them can infect another 4 individuals. And then you will see how rapidly the infection kind of it spreads into the community. But when we have a phenomena of herd immunity, then there are many people who are already kind of immune. So this immunity may be because of their exposure to the infection, or it can be because of the vaccination. So when this immunity is there, then obviously the susceptible people, their number in the community goes down. And that's how basically the progression of the infection, it slows down. So that is, I think, the reason, why we saw, in so many countries, people were talking about the herd immunity. But now, the question arises that, can herd immunity help to stop, the coronavirus? The research, most of the research, it says that in a given population, around 50 to 70% of the population needs to be immune, in order to get the benefits of the herd immunity. And to be honest, when we talk about the coronavirus and we talk about the hospitalization rate and, the mortality rate and all those complications associated with the, coronavirus, if we go by that route, where we wait that, till the infection is so much prevalent among the population that we can get the benefits of herd immunity, there would be a lot of a loss. We already know that, in the world, there are right now around 5 million confirmed cases of coronaviruses. But I think a number of studies, and I think just a few of them I have cited, here on my slide. For example, one in Wuhan, China, which was conducted, I think, in about 90,000 people, and it showed that only 2 to 3% of them, they had immunity. And similarly, in Spain, another study showed, there were only 5% who were immune. And I think one study, which has very recently been done in New York, which was also, I think, the governor of New York last week, he talked about this, results of this study as well. That showed, even though a little bit higher number of the people who were kind of immune, but still, that number is very low, which was around 21.2%. So literally, if we talk about the herd immunity, then that means a lot of population would need to have that, either infection, or the other scenario is we have the vaccine available and we vaccinate so many people that, this chain of transmission, which we define by this, R naught, or the reproductive number, it's kind of broken, so that one individual who is infected, he or she cannot infect so many other people. So I think this concept of herd immunity is good. And as you have already shared in polio and in so many other diseases, where the vaccines are there, we have benefited. And that can be a situation, but I think as far as the coronavirus is concerned, this is something which is kind of very premature, because it has a lot of repercussions when we say that herd immunity is something which we can benefit in the coronavirus pandemic.
Okay, thank you, Dr. Imran. So what I can understand, because I was watching a lot of conspiracy theories and a lot of videos circulating from supposedly very highly qualified people, and they were mentioning if we are stopping people from going out, that will limit developing herd immunity, and because there are political things are going on. So from what I hear from you, that at this stage, herd immunity is not a thing to which we can rely on. So I think once we develop some sort of immunity or some sort of vaccine or something, then it may come into play. But right now we are still in uncharted territories regarding this coronavirus.
Yeah, Dr. Amir, I think you're absolutely right. So regarding coronavirus, there are so many things that need to be learned. And I think public health is also equally learning. And you are absolutely right. If we just totally rely on the herd immunity in coronavirus, then probably in terms of the damage, it will be way more. So I think as far as all the public health measures are concerned in terms of the prevention of coronavirus, they are all very important. And I think more focus should be on the development of the vaccine, so that we can have it available as soon as possible, and then as many people as possible can be vaccinated quickly, so that we can get benefit of the herd immunity.
Okay. Thank you, Dr. Imran. So, Dr. Mirza, so just I want to know what are the different tests available to diagnose COVID-19 here in Alberta or all over the world, and what are you be doing here?
So what I alluded to in my previous answer, that there are two major categories of tests. One is the nucleic acid test, which uses reverse transcriptase polymerase chain reaction to identify the viral RNA and the structural proteins of the virus. And the others are the antibody or antigen tests for the virus. There's a sort of a huge effort going on across the globe to develop these tests. The Foundation for Innovating Diagnostics has more than 675 tests listed there, developed by academic labs, commercial labs, and also private laboratories. So these tests are becoming available at varied pace. Here in Alberta, we are relying on the RT-PCR or nucleic acid testing, and if you go to Alberta Health Services website, you will find 3 or 4 categories of people that are being tested. Of course, those who have acute infection and are presenting with symptoms, people that they have come in contact with, healthcare workers taking care of these patients. And the 4th category, which was for a short period of time, for almost a week, and mostly in Calgary, was to test 1,000 people a day who go out of their homes to work and are asymptomatic. And that is to sort of have an idea of the prevalence of the disease in the community, because most of the cases in Alberta are in the Calgary region. And in terms of the antibody tests, they are not currently being looked at least in Alberta. But what I can tell you is that there are 2 ELISA-based tests that allow you to also quantitate the level of antibodies that a patient may have. And then there are a lot of point-of-care tests that are being developed that, you can do a pinprick and put a drop of blood on it, and you will see they use the lateral flow technique to see, bands of color, just like a pregnancy test, if you may, to see if you have an immune response, which generally tells you that you have been exposed to the virus and you have may have been asymptomatic or had mild infection with the virus. So if we go with the tests and how they perform, I'll just quickly share with you my screen. So here, I just want to highlight some of the tests that are currently being used. One is, as I said, the RT-PCR test. And one question that was asked earlier was also that how long does the virus last? So what I can tell you is that on the first week, the test has a very high sensitivity and specificity, close to 100%. And that is true for most of the tests that are being used across the globe. But as patient recovers and starts mounting an immune response, the positivity rate, which is shown in the downward slope of the graph, keeps going down. And most of the patients by week 6 have no detectable virus. And so the average median duration for virus detection is 24 days. And all patients are negative by 6 weeks. This data is based on a study that was published from Wuhan on 56 patients that they tracked over a period of 6 weeks. The patients who had prolonged viral shedding were older patients, patients with diabetes, and patients with hypertension. So one of the questions that arises is that once people have been discharged after week 3 or week 4 of their acute disease, say from a hospitalization, or if they had mild symptoms and they have recovered from home, can they be shedding the virus? And the answer is that it is possible that they may have recovered and still be positive by the test. But is that a viable virus? Is something that a study that was done in UK, where they tested 9 patients, and all of them had by culture to see if they had viruses that can cause infection, and the answer was no.
Mhm.
So the testing that is currently being used is RT-PCR for acute infection. Serological tests are just coming online right now, and they will be, as we mentioned earlier, would be useful in the public health setting, and in terms of canvassing the population and seeing what is the prevalence of disease.
Thank you, Dr. Mirza. So at this time, there is no blood test. So, but maybe in the weeks. For
So
now, we
yeah, so serological tests are based on blood,
Yeah.
whereas nucleic acid tests are based on nasopharyngeal and other respiratory specimens. To my knowledge, the virus has not been detected in the blood, but blood is not your logical sample to be taken for this infection. So as serological tests become more and more prevalent, and there are more than 200 different tests that are out there, which have not been tested and have not been compared with each other. We don't know, the clinical sensitivity and specificity of those tests. So I think with time, we will separate the wheat from chaff, and we will be able to use tests that are truly informative in the public health sphere.
Okay, thank you, Dr. Mirza. So I can see some participants are asking questions, especially from Dr. Mirza, and we'll come to them after when I talk to Dr. Imran. So my question with Dr. Imran is that a lot of emphasis is being placed on contact tracing in this phase of this pandemic. Why is it important? Because they say that if we develop some contact tracing, we'll be able to control the second spread, and we are opening the economies. So there is an important, with that term, contact tracing has been used, apps have been developed. And so I want to know what is contact tracing.
Yeah, thank you, Dr. Amer. I think this is a very kind of relevant topic, because so many people are talking nowadays about the contact tracing. So I know we have a limited time, but I'll just try to kind of briefly explain when we talk about the contact tracing, what does it mean? I think there are few areas that we need to very clearly understand, because in the public health we have seen people using these terms interchangeably, and they are kind of confusing. So when we talk about the contact tracing, we should clearly know who is a case and who is a contact, and we should have a clear cut understanding of what we mean when we say isolation and when we say quarantine. And then some understanding of I would say the incubation period and the infectious period of the coronavirus is very important. And I think that is something which enables us basically to implement the contact tracing. So I'll just try to go through a couple of 3-4 slides just to make it very clear. The first thing is what is contact tracing. So I think when we talk about the contact tracing, again, that issue of the R0 or the reproductive number, it becomes the central. So if you look at this slide, and especially on the left side, towards the lower side, you will see there is an R0 of 2, which is we say for coronavirus, the reproductive number or the R0 is around 2 to 3, which indicates that one person who is infected will infect the 2 people. And we see if that situation continues very rapidly, how many people will become infected. But if through the contact tracing, the contacts of the cases, we can stop the transmission, then literally this R0, once it goes down, the number of the new cases, it will go down. As you can see in the picture on the right side, where the R0 value is 1, and we can see that only there are a few people who remain susceptible, and the infection goes into them. When we talk about the cases on contact, I think there are some confusions as well. So we should be very clear about these definitions. So I'll not go into the details, but I just want to emphasize over here that when we say a case of COVID, then this is a case usually who has a positive a lab test. But I think we have also seen in some of the remarks by Dina and Shah in the province, that we also talk about the probable or the suspect cases as well. But when we talk about the contact, then contact is a person who has been in contact with a case during the illness, or at least 2 days prior to the illness. And then when we talk about this whole issue of the contact tracing, two other terms which I would say are very important, and they are the isolation and quarantine. And these two terms are also kind of used interchangeably. So when we say isolation, the isolation is basically for the cases. And this isolation, the duration, it has to stay actually for the duration of the infectiousness. And when we talk about the quarantine, this quarantine is basically for the contacts. And this has to be for the 14 days, from the start of your contact with a case. So this is something which needs to be understood. So from this, picture, I'll just try to explain that in the case of the coronavirus, we say that the incubation period is usually around 14 days. And what we have seen so far from various studies, that about 5% of the contacts who become in contact with a case, they actually show signs and symptoms in about 2 days. And about 50% of them, they show symptoms in about 5 days. And about 95% they show symptoms in about 14 days. So the incubation period is basically the time from where one gets infected till the time one shows the symptoms. So once the symptoms are there, then from there the onward the disease is there. But when we talk about the infectiousness of the coronavirus, the studies have shown that this infectiousness starts 2 days prior to the onset of the symptoms, and then it's at its height when the symptoms are there, and then gradually it stays there and then it fades out. So it's very important for us in the contact tracing from the public health point of view, that we know that how many people, or who are the people who have been in contact with that case, specifically I would say 2 days prior to the onset of the symptoms, and then throughout the infectious period. Because I've already told you that as far as the incubation period of this disease is concerned, for 50% of the cases, it's around 5 days. And if we consider that, when the symptoms appear, a person becomes infectious 2 days prior to the appearance of the symptoms, then literally that window of opportunity that we have is very narrow. It's just about 3 days. So during those 3 days, basically, we need to find out those contacts and put them in quarantine. So that's why this issue of whole the contact tracing, it has become so important. And as I've already explained in this diagram, I'll not again go into the details, but it just shows that for the cases, it's very important that from the onset of the symptoms, the case has to be in isolation for 10 days, or when the symptoms subside, especially the fever, it has to be not there for 3 days. And when we talk about the contacts, the quarantine has to be for 14 days. And if it is kind of a regular contact of a person with a case, then it has to be 14 days from the last, day of contact. But I think, Dr. Amir, coming to your second point, and that is about the technology, I think in the contact tracing, scenario, this technology, plays, a very important role, because it can bring in a lot of efficiency in terms of the speed and the improved processes as well. And we have seen the technology is being used in various ways. We have seen so many electronic databases and tracking systems. We can have automated setup of calls, and where we can actually help those who are in isolation and quarantine. But I think the most important question when we talk about the quality is of the technology is to strike a balance, when we say that something which has public good value, how it has to be balanced with the privacy, autonomy, and confidentiality issues. As far as the tracking apps are concerned, I think now we have seen so many countries in the world, they have all those tracking apps available. in China, in Australia, Korea, Singapore, and even in Canada as well. And just a few weeks ago, even in Alberta, this new tracer app, which is known as the Alberta Trace Together, it has been launched. And we heard from Dina Henshaw that just in a few days there were so many people who kind of downloaded this app. But I think when we talk about even these apps and their values in the contact tracing, we need to be careful, because it depends upon the number of the people who actually have this app. And we also need to literally understand that those who are contacts, whether they have been exposed or not. And then, as I've already told you, that there are a lot of issues around the autonomy and confidentiality as well. Going forward, I think we will see more and more apps coming in, and more kind of advances into the technology, which will definitely help in kind of improving this contact tracing. And to be honest, right now, if you see our response in Canada or in in Alberta, I think on the public health side, a lot of weight and importance is being given now to the contact tracing. And we are trying to find out those contacts as quickly as possible and trying to put them in quarantine so that the others can be saved.
Okay, thank you, Dr. Imran. So in this scenario, in this stage of a pandemic, when we are opening up, we are opening the communities and the economies, contact tracing may be a very important point where we can control the second spread. Because we are fearing that there is a possibility, if we do not take precautions and we are not able to trace the contacts of the infected cases, there may be a second circle where will be which may be much more severe than the first. Now, I'll go to Dr. Mirza. There is a question asked by SNAU with Dr. Mirza, that how are nucleic acids isolated from the serological sample of a patient? And is the presence of any specific antibody indicative of infection in the beginning, as in before symptoms can be observed?
So I would refer you again to the graph that I showed earlier, and maybe I can show that again, just to answer this question. So as you can see, there is no immune response in the acute phase of the disease as once the symptoms start. So in week 1, the only way to diagnose a patient with COVID-19 is to do the testing for the virus using RT-PCR or nucleic acid testing. The immune response starts quite late in an acute phase. In second week after the onset of symptoms, and it sort of reaches its peak in the 3rd week. So there is no place for antibody testing in terms of whether somebody has an acute infection when they present, in a healthcare setting. We need to do an RT-PCR based test to diagnose them. It's the antibody tests are useful to identify people who have who had infection with COVID-19, and then again for as I said, for public health perspective. I hope I answered the question. So.
Thank you, Dr. Imran. I hope Asan's question is answered, so that the nucleic acid is taken from the sample from the swabbing.
Correct.
And no
respiratory sample. It's a respiratory sample. It's not a blood sample.
Yes. Yeah. So I want to ask Dr. Imran another question. So, because from a public health perspective, and what is the global strategy to combat COVID-19, and how is Alberta following this guidance?
Okay. So thank you. I think, again, try to just share my screen with you. So I think, Dr. Amir, if we talk about the global strategy, in all these pandemics and otherwise, in the public health, we always take guidance from the WHO. So right from the day one, you have been hearing about this thing that we need to flatten the curve. So I think as far as the goal of the global strategy for the COVID-19, right from the day one has been how quickly we can slow down the transmission, and we can reduce the mortality associated with the COVID-19. But to be honest, the WHO has put forward a document, and that document basically, I would say, outlines the 5 key areas, which are kind of I would say the pillars as far as the COVID response, global COVID response is concerned. So these 5 strategies, or 5, you can call them pillars or objectives, are: number one is mobilize all sectors. So that COVID-19 is something which is not a thing which can be responded by one sector. So it has to be kind of a multi-sectoral response. And to that effect, we have seen, in Canada or globally, or even in Alberta as well, that right from the beginning, when this COVID-19 started, there was kind of a multi-sectoral response where all the communities, they came together and they started fighting this infection. The second pillar of this strategy is the control of sporadic cases and clusters, which I think is very important. And specifically, I think when we talk in the context of the Alberta, we have seen in Canada overall or in Alberta, there have been too many outbreaks in certain settings. So those clusters and those sporadic cases, their control is something which is very important. And in that context, the strategy to find out, to test, isolate, and care for the cases, and then at the same time quarantine the contacts is the way to go about. And that's what we have seen even in the Alberta is. The third, the strategic pillar is basically the suppression of the community transmission. And again, since this response started in Alberta, we have been talking about the community transmission. And the community transmission is something which is very important, and this needs to be controlled. And throughout the world and in Canada and Alberta, we have seen so many efforts going on the community transmission. And then the fourth pillar of this strategy is the reduction of the mortality, because we know that with the COVID-19 there has been high mortality, especially in the older population. So it has to be reduced. And as far as our health systems are concerned, especially on the clinical side, they have to have all those equipments and I would say the availability of the services which can actually help reducing the mortality. And then the final pillar is basically development of the vaccines and therapeutics. And that's the way where I think globally all the efforts are going on right now. And we have seen even in Canada as well, Justin Trudeau recently announced around this $450 million, which will be going towards research. So to be honest, if you look at these 5 pillars, and then, at the same time, if you look at the response in Canada or Alberta, you will see this is the exact strategy which I would say Canada and Alberta has been following. And I think most of the countries right now are trying to follow this strategy. They might be at various levels, in terms of each of these strategic pillars, but that's the global guidance, and that's where I think the solution of this problem lies, and that's where more work needs to be done.
Thank you, Dr. Imran. So I have one more question for Dr. Mirza from Dr. Majid Shakur. Can you please clarify neutralizing antibodies? Also on immunity spectrum, do you expect SARS-CoV-2 to be similar to SARS-CoV-1?
So the neutralizing antibodies are against the receptor binding domain on the spike protein. It is that domain that actually attaches or latches the spike protein to the ACE2 receptor on the host cell. And as I said, testing for these specific antibodies is generally difficult. And most labs sort of assume that if you have a very high titer of antibodies, that you must have or may have some neutralizing antibodies there against the receptor binding domain. In terms of the response, we can speculate, as I said earlier, that what we know that from our experience from SARS, or classic SARS, as it's called now, and MERS, is that they last for a couple of years. The response in those who are infected lasts for a couple of years. we can assume that it is the case, or maybe the case in this particular disease, but we don't know. Only time will tell.
Okay, thank you, Dr. Mirza. I think, I hope, Dr. Shakur, that your question is answered. So we are coming to the close of our session. One last question from Dr. Imran, because it is very relevant, and that question I want to ask. Because now in Edmonton, the economy is open. Calgary, it is partially open, and in the next few days, it is opening up. And as the economies have started to open up, what are some of the key measures to ensure that the transition, that is a steady state of low level or no transmission of coronavirus? What can common man do in these circumstances?
Yeah, no, thank you, Dr. Amer. I think we have already kind of crossed our time limit, so I won't go into a lot of details. But I think when we talk about I would say opening of the economies and opening of the businesses, I think there are three questions, primary questions, which need to be asked I would say at a government level or at the decision making level before opening the economies. First question is whether the epidemic is under control. Second, I think the most important question is that whether the healthcare system is able to cope with the resurgence, if in any case, as you were already saying, when the economies and the things will open, there is a possibility that there might be second or third wave. So is our health system basically ready to cope with that kind of resurgence? And third, I think a very important thing is is our public health surveillance system, is it able to kind of very quickly, I would say, detect the cases and the contacts and track them? So I think if in a province or in a country the situation is such that we have a clear-cut answer of these three questions, then a gradual move towards the opening is something which should be thought. And that's what we are seeing right now, that globally the countries are taking very kind of calculated steps to reopen their economy. And that's what we have been seeing in Canada and also in Alberta. Because I think if we talk about the first question, which is about the epidemic control, we have seen that over the past I would say few days to few weeks, that the number of cases have literally gone down. The hospitalization rate has gone down. The mortality, it has not literally gone down, but still it's not to that level to which the models were kind of projecting. And then also I think countries like Canada and many other countries in Europe as well, and states as well, they've also kind of gauged that how good their health systems are and how prepared they are in terms if there is any resurgence. And also I think we are kind of beefing up our surveillance system as well. So we are working on all these apps so that we can have very fast contact tracing as well, and putting people the cases into isolation and contacts into the quarantine. So with all these things, it looks that with a calculated move, I think opening the economy is something which we are seeing, which is kind of acceptable. But at the same time, I think the most important thing is our individual role. As I think the economies are open, that doesn't mean we also need to open everything I would say very quickly. All those measures, for example, the social distancing, use of the masks or the hand hygiene and all those things, they will become, I think, in the coming days way more important. And one thing we all know, until and unless we have an answer to the as far as the treatment or the vaccine for the COVID-19 is concerned, we'll have to survive with all these public measures. So I think on the individual level, the most important thing is that as the businesses are getting themselves ready for this new scenario, as an individual and as a community, we also have a responsibility to comply with all that guidance, the public health guidance, which is there to save individuals and then at a large to the communities from the coronavirus. So I think we are moving in the right direction. And if that is done in a proper and in a calculated way, the things seem they will be well controlled.
So thank you, Dr. Imran. From what you said, what I get is that we have done a good job by flattening the curve and by minimizing the hospital admissions and ICU admissions. Now the job is not done.
Exactly.
So when the things are opening, we still need to follow and continuously follow the guidelines provided by the health professionals and our authorities. And in this way, we'll be able to avoid a second spread, a second cycle of a big pandemic or epidemic.
Absolutely right. Absolutely right, Dr. Amir.
I think so. At this time, we are coming to the end of this session, and for this is being recorded, and this will be available on the MDI group and on the YouTube MDI International YouTube channel. And I thank you, Dr. Imran Mirza and Dr. Mohammed Imran, for their expert and enlightening talks. And at least that made me richer in knowledge significantly.
Thank you. Thank you, Dr. Amir. And thank you, Dr. Imran.
Thank you
And
to
thanks
both
to
of you.
MDI.
Yeah, it was an honor. Thank you. I
Yeah,
appreciate
it
it.
was an honor. Thank you. Thank you very much.
Thank you very
Take
much
care.
from MDI, and we will be continuing our weekly health hours in the coming weeks. So stay tuned. Thank you very much.
Thanks. Take care. Bye-bye.
Thank you. I thank all the participants for participating and asking questions. Thank you.
Thank you.